correct. I'm Wendy. I'm Wendy Smith. So Wendy Smith is my sister, and she's the pediatric dentist that I think presented a few months ago. And then I, as the moderator mentioned, I do work here in the Bay Area, and I'm an ENT, or also we're called head and neck surgeons. And so, I'll kind of go into that a little bit. Let's see. Okay. So there's a lot of different names for our group, or the type of doctor that I am. And so historically people called us ENT. So that's, I'd say, what we're most commonly known as, where ENT stands for ear, nose, and throat. And then another word for us is otolaryngologist. So that's the more technical name. Oh, can you guys see my screen now? Perfect. And then head and neck surgeon is really the word that or the term that most people nowadays like to be called. That's sort of our preferred name. So like that's the name on the entrance to our office. It says head and neck surgery. Now, that being said, we do a lot of things that don't involve surgery. A lot of times patients come in and they're a little nervous. They walk in the door and they say, oh my gosh, does this mean I'm going to have surgery today? Or are you definitely going to do surgery? And the answer is we actually deal with a lot of medical diseases too. So there's a lot of things that we do to help people that doesn't involve a surgery at all. But as you can tell from the name, ear, nose, and throat, our main goal is to help patients with diseases related to the head and neck area. Now, we don't deal with the eyes. That's a totally different specialty called ophthalmology. And we don't deal with the brain or the spinal cord. Neurology or neurosurgery deals with the brain. And then, like I mentioned, we also don't do the spinal cord. So there's spine surgeons. But basically everything else is in our territory. And so some of the really common things that we deal with are things like nosebleeds, sinus infections, sleep apnea, where people are gasping in their sleep and snoring and they kind of stop breathing. We deal with things related to the ears, so like holes in the eardrum, cysts called cholesteatoma in the ear space. We deal with cancer of the head and neck. We deal with vocal cord diseases. We deal with dizziness or vertigo. So all sorts of stuff sort of falls into our territory. And as I mentioned, we're not necessarily doing surgery on everybody, but we do a lot of procedures. So even if we're not doing a surgery on someone per se, when they come into our clinic, most of my day, I'm doing some sort of procedures on the patients that come in. And that's really the benefit of the training that I have, is that, I have a lot of hands-on skills that primary care doctors can't do in their office. So a typical workflow would be that a patient goes to the primary care doctor and says, I've got this issue, and the primary care doctor does whatever they can do to help them. And then when they sort of get to the end of their skill set and they're sort of beyond what they can do to help the patient, then they send them to us. Why did I become a head and neck surgeon? So actually, both my parents are primary care doctors. And when I went to med school, I thought, if there's anything that I like as much as I like primary care, I'm going to do that other thing. That's the truth. I sort of saw their lifestyle growing up, and I had a feeling I would like that job, but I didn't want to do it. I don't really know why at this point. Not sure why that was my sense of their lives. I don't know. It may be related to the fact that my dad was a pediatrician, and I think he always wanted to be a surgeon, I think secretly. So maybe that influenced me in some way to be drawn to surgical specialties. But I think in the beginning of med school, we did anatomy, where it is very hands-on. So you're dissecting cadavers. And I think at that point, that's where I realized that I really liked working with my hands. And I started to think maybe I'll be a surgeon. And then I really didn't know anything about ENT. I'd never heard of that before I was in med school. But some of my friends did a rotation in ENT when we were first or second years. And they really liked the person that they were working with. And they encouraged me to work with this guy whose name was Chris Moe. And so I just reached out to him. I didn't do a rotation initially. I just said, hey, I'm kind of interested in surgery. Can I come hang out with you? And he said, no problem. And so I just randomly went to the operating room one day, and that was my first time in the OR, and I just loved it. So he allowed me to do some hands-on stuff as part of the case, which in retrospect were very simple things, but they felt really exciting as a second-year med student. And that Dr. Mo was just very dynamic and interesting and really engaged his students. And so I think that was really what made me interested in it. And then as I got to know ENT, it just seemed like a very good fit for my personality. And as you go through med school and, sort of through training, you'll see that each specialty sort of has its own personality or type of people that it tends to attract, which makes sense, that sort of, people would be drawn to their specialty for a certain reason. And that was just how I felt about ENT. And to be honest with you, I still feel that way. Even after all this time, I still feel like this really is the field that's the best fit for me. All the other jobs that I've seen in medicine, I haven't seen one that I think would be a better fit for my personality and just what I like to do all day. So what do I like about ENT? It has a lot of variety. So we see old patients, young patients, I see healthy patients, I see sick patients. I really just see, the whole spectrum of people that are out there. So I really like that. It's very hands-on, as I mentioned, my whole day. It's pretty rare that I'm literally just sitting there and talking to a patient. I mean, almost every patient visit, I'm doing some sort of procedural type thing. So I really like that. It's busy. I like that too. I'm the type of person, I'd say if you're lazy, like don't become a surgeon because we're sort of on our feet, running around all day, just doing a lot of stuff. And I like that. I really like patient connections too, though. So there are certain fields that you could go into where you really aren't talking to patients very much. And that's different about ENT or about head and neck surgery. Because we spend a fair amount of time in clinic with patients who are awake, meaning not in the operating room with them asleep. I really get a chance to connect with people. And it's amazing to me as a physician that people walk into my clinic. I don't know them at all. I've never met them before. And within 20 minutes, they're telling you very personal things about their life. So they're telling you things that they may not share with their friends or their family members because they don't feel comfortable. They're just these topics. And I'm not necessarily in a job where I need to know all the details of certain parts of people's lives, but a lot of times stress plays a big role in many different diseases that people has. And so a lot of times just when I ask that simple question of, what's been going on in your life lately? How has your stress level been? That is something that really opens up the door to people sharing with you. And like I said, that's a very cool thing about being a doctor, whatever kind of doctor you are. Like I said, most fields will give you that kind of connection to patients, which I really like. In my job too, we spend part of our time doing what's called minor procedures. So that just means removal of little lumps and bumps. So lipomas or cysts or skin cancers, those are procedures where somebody would come into my office and we'd spend about an hour together and they're awake during that procedure. We do it under what's called local anesthesia. And during that time, that's when I really get to connect with patients in that way, where it's just an hour where I'm working and doing something, but, at the same time, I can talk and have a conversation with them. And, it's really great. I'll hear stories about how somebody met their wife 60 years ago, or what's going on with their grandkids and their family members. And we really get to have sort of an in-depth conversation. And like I said, I think that's a really cool part of my job, which, like I said, isn't necessarily specific to ENT, but it's I think very specific to being a physician and being a good physician when you're able to connect with patients like that. And then the other thing I love about my job is just that I do have a good work-life balance. So at this point, I work 4 days a week, and I really like that. I would say it's, I worked full-time 5 days a week for 5 years, and that was tough. I mean, it's like I said, they're busy days. But the cool thing about medicine, and certain roles or jobs that you could take is just that you do have that ability to cut down to 4 days a week. And not commonly are people 3 days a week, but that is, also an option out there for some folks. But I do feel like I have a good work-life balance. So I have a very rewarding career, but that's only 4 days a week. And then usually on my day off, I am able to not do work. Sometimes I do have to catch up on notes and things, but there's a lot of my days off where I don't do any work at all. And I think that that's really important, and it helps me be a better doctor to have a little break from it. So I think I think that's cool. Let's see, how did I get here? So it's hard to remember back to high school and what sort of activities I did then, but probably just guys are already doing. I just remember sort of focusing on getting good grades and getting good test scores. I certainly did sports and some clubs to get some leadership experience. But like I said, I can't really remember specifically at this point what I did way back then. When I went to undergrad at Stanford, I majored in human biology with a focus in neurobiology. I did an honors thesis. I did a lot of volunteer activities. And certainly I'd say one of the most important in terms of preparing for med school was volunteering at a free student clinic. And certainly for people, when you're thinking about going to med school, they want to make sure that you have some exposure to hands-on medical experiences to ensure that you really know what you're getting yourself into and that you're making the right choice. When you're applying for med school, really what they want, they want to build a diverse class, but they also want people to succeed. They don't want to have somebody start and do a year or two of med school and then realize, oh no, I didn't, this really isn't the right fit for me. And so as much as you can do in high school and in undergrad to like say, get hands-on experiences in medicine, where you're really exposed to what the day-to-day commitment is like. I think that that's important for, preparing yourself for med school. I also did a lot of other experiences. So I volunteered with a group that partnered college students with ALS patients. ALS is a neuromuscular disease that's slowly progressive and affects somebody's ability to do all sorts of day-to-day things. They ultimately end up paralyzed, but they kind of slowly lose their ability to swallow and move their arms and legs and those sorts of things. And so we would just be paired with an ALS patient and we would go to their house and just sort of visit with them. I don't remember doing anything specific to help this patient other than really just talking to her, which again is sort of a precursor to what life as a physician is like, because really, a lot of what you do is talking to patients and helping them just by talking to them. But I did that. I helped edit a poetry anthology. So, just sort of a variety of activities. I did a lot of research as an undergrad, and I would say that's probably also an important component of preparing for med school, something that they're certainly going to look for. And then I chose to take a year off after I finished Stanford, and I spent a year still at Stanford doing research on bioterrorism. So it was the Agency for Healthcare Quality and Research, and it was a really amazing time to be doing that. Nowadays you'd say bioterrorism, of course, we always talk about bioterrorism and think about those sorts of things, but really at the time where I joined this project, it wasn't in the forefront of people's minds, but in the year that I was working in this job, it did become that way because we had some scares with anthrax being delivered in the mail, and that was the year of 9/11. So there was a lot of stuff going on that year that really sort of thrust the work I was doing into the spotlight. And so that was pretty cool to be doing a project like that. It also was just nice to have a little break from school, although certainly a lot of people do continue and just kind of go straight through. But, I had a lot of friends that did what I did, which was take a year off. And like I said, I think we all sort of appreciated that time. And then after that year off, then I went to medical school. I did that at UC San Diego. And so that's, 4 years. And that was good. And also, this sort of preparation stuff never ends in med school. Then you're sort of trying to build your resume for residency. So, you're pretty busy with studies, especially the first 2 years. But, some of the activities I did at that point, so I continued my research. And I also I organized a speaker series about women in medicine, and sort of facilitating, again, how do these women in various fields facilitate work-life balance, thinking about that and sort of, presenting to the med school students. I worked in a free clinic during that time. So just those sorts of activities. So again, you just kind of continue to do all these extracurricular activities throughout your whole training. And then after that, then I got my residency position. So I was also at UC San Diego. Any sort of surgical specialty is going to be at least a 5-year residency position. And that's different as compared to medicine or pediatrics, which are 3 years. So it's a much longer training to become a surgeon, which makes sense because, you're not just gaining the medical knowledge, you're also really having to learn a whole set of surgical skills. And really that's most of what you are doing in that time period, is a lot of time in the operating room, learning how to do the mechanical part of what you're going to be doing in your job. Because really up until that point, you don't know how to do those things. You don't know how to sew. You don't know how to dissect out a neck or structures and do all those, all these sorts of things. I mean, there's like hundreds of procedures that we learn how to do over that time period. So it certainly sounds like a long time, but I think it's a necessary time. My residency was 6 years long instead of 5, because we also had a year of research built in the middle of our program. Nowadays at San Diego, it's a little bit more variable. Some people do a 5-year program, so they don't do any research. Some people do 2 years of research, and then occasionally people nowadays do 1 year of research. But when I started there, most of us were doing 1 year of research, which I have to admit, I really liked. That was one of those things I wouldn't have necessarily have sought out, just because you kind of want to be done and finish things. But just as it did with my other year of research, it just gives you a little break. And I felt like I was really able to accomplish a lot of life goals during that year. So for instance, I ran a marathon. I went and spent 3 weeks in Nepal and Bhutan. I just did a lot of things that were on my bucket list of sort of personal life. Because on the flip side of all this time that you spend in training is that, really, I mean, when I finished all this stuff, I was in my early 30s. So you've spent all of your 20s and sometimes the first part of your 30s being really busy and working really hard and spending a lot of time on your job. And so I really liked my years of research as breaks within there to have, reclaim a little bit of my personal life. All right. And then once I finished, then I started working at a place called the Permanente Medical Clinic, or medical group, which is linked to Kaiser. So that's what most people think of as a Kaiser physician, but we're actually separate. And I've been there for almost 10 years now, a little bit over 9 years. And so, and I would say my life as a surgeon sort of out of residency is actually a lot different as compared to life in residency. So as I mentioned, in residency, you're spending a lot of time in the operating room. I mean, I would be in the OR easily 4, sometimes 5 days a week. We didn't want to go to clinic very much. That was not fun. And so, but you're spending a lot of time in the operating room. You have a lot of late nights. And now it's really the flip side of that. I actually spend a lot of time in clinic and not that much time in the operating room. So every job is going to be different. But in my job, we're usually in the operating room only once or twice per month. So not very often. Like I said, most days that we're in the clinic, I have half a day per month that's admin time. And most people have some sort of administrative role, they're on some sort of committees. But unless you're really high in the leadership positions, you don't have a whole lot of time developed or devoted to admin type stuff. We do a little bit of remote work. So kind of earlier in the pandemic, we had many more days that we were at home working remotely. But as you can imagine, there's only so much you can do with a video visit for a job that's very hands-on and procedural. So we nowadays just have 1 day a month, maybe 2 days a month that we're home for the full day, just doing, a series of video visits all day long. So like I said, most of the time I'm in the clinic. Clinic starts at 8:30, ends at 5:30. So again, nice work-life balance. It's very predictable, which is great. I really like that. I usually see 15 to 20 patients a day, which probably sounds like a lot, but actually compared to many of my, many people outside of Kaiser, that's a pretty small workload. So I have a lot of friends that see maybe 30 patients a day. And it really just depends on how the clinic is structured. So people that are seeing 30 clinics or 30 patients a day usually have like a scribe with them or some way that they're not necessarily charting all that time. Whereas at Kaiser, the model is like, you know, we're seeing less patients, but we're really doing all the computer work ourselves as physicians. And as one person once said, you know, or somebody once said, I think my chief was just like, how do you want to spend your time? You know, do you want to spend your time just cranking through a bunch of patients, but not really being on the computer? Do you want to spend your time where you're seeing less patients, but you're doing more computer work? I mean, you know, it kind of is what it is. You only have so much control, but those are things that, like I said, can vary. Same type of job, but just in different practice settings. As I mentioned, in the clinic, I'm doing a lot of procedures. And so the most common things I do would be things like cleaning out the ears. So we have a microscope. So in our clinic, patients are laying down. And then we've got a microscope that gives us light and magnification to look in the ear canals. And then we do all sorts of things. So cleaning the ears, I drain fluid from the middle ear space. I put in ear tubes. So I do all sorts of ear stuff, and that's a really common thing because so many people have earwax to clean out. We drain abscesses. So abscesses are like pus pockets underneath the skin where it's infected. And so we're making a cut in the skin and opening it up and releasing the pus. As I mentioned, we do minor procedures, which are longer, you know, kind of blocked out, again, usually about an hour at a time, where we remove skin cancers, cysts, lipomas. We do what's called fine needle aspiration. So those are like if you had a lump in your neck and we're trying to figure out what is caused, you know, what's this lump from? Is this cancer? Is it something else? We put a little numbing medicine in the skin and stick a needle in there a few times to draw out some of those cells and put them on slides and then see if that helps us make a diagnosis. And then one of the most common things I do, like all day long, is something called a flexible laryngoscopy. And you know how we typically explain this to patients is that it's a camera exam. And so this is some pictures of like, what does a laryngoscope look like? And so on the right-hand side, you can see, you know, it's kind of a long, skinny instrument, and then it's got an eyepiece up at the top. Now, this is what it would look like if I was just doing it on somebody at their bedside, like if I went to the ER or, you know, saw an inpatient. In our clinic, we have it set up so it's connected. It's got like the camera's connected to a screen. So you as a patient and I as a doctor can both look at this screen together. And it's really cool. It's actually one of the best parts of my job. It's like playing a video game, but using that as a tool to help teach people. And so on the diagram on the left, you can see, you know, this is kind of what it looks like. We put it through somebody's nose. Okay, so I put some numbing medicine in there first, and then I take the numbing medicine out, and then I put the camera in. Okay, and so that kind of long, skinny part goes through the nasal cavity. And sometimes we stop there. So if somebody's coming in and they've got a sinus infection or I don't know, polyps in their nose or something like that, you know, then sometimes we're just looking in the nasal cavity. But most commonly we go, you know, a little bit deeper on one or both sides, and then we're looking all the way down to the vocal cords. And so we use that to diagnose all sorts of different things. You know, a lot of times we can diagnose cancer with it. We can diagnose issues with the vocal cords. We do it as part of our sleep apnea evaluation for adults. I mean, it's just like all day long, I'm looking at people's noses and throats with this little camera. So like I said, it's a pretty quick procedure that I can do. And like I said, it actually, I really like it too, because especially with having the image on the screen, I can really use it to help teach patients about their bodies. We also use it for reassurance. I mean, to be honest with you, a lot of patients come in, they're nervous that they have cancer because they're having some throat pain or some voice changes or, you know, something going on that they don't quite know why they're experiencing that symptom. And in their mind, or because of Dr. Google, you know, they're scared it's because of cancer. And the cool thing is, like, you know, it just takes me a few minutes. I do this quick procedure. We look together. And then at the end, most of the time I say, nope, no cancer. Like, I have really good news for you. So that's a very cool thing that I get to do as part of my day. As I mentioned, we're not in the OR that much, but you know, like I said, we do, it is a surgical specialty. So we do a lot of surgeries too. Most common surgeries that I do as a generalist, and I guess I should stop here and just mention too that there are, within head and neck surgery, there are a lot of subspecialties. So I'm a generalist. That means I decided not to do a fellowship or subspecialize in anything. But the types of things that people could subspecialize in include facial plastics. So that's like, nose jobs and cosmetic procedures, as well as advanced skin cancer reconstructions. There's ear specialists called neurotologists. There's sinus specialists. There's people that specialize in the voice box area, what's called laryngology. There's people that specialize in head and neck cancer. There's sleep apnea, although that's less commonly done. And then there's pediatrics. So like I said, I chose not to do that. So what I do is more of the, what we call general cases, or the kind of more straightforward kind of cases. And so like I said, a lot of tonsillectomies. I also do a lot of something called a septoplasty. So your septum is the divider between the two sides of your nose. And as you can imagine, a lot of people have some curvature to that. So it kind of curves into one nostril or the other nostril, and it narrows that person's air passage in their nose. And so they feel congested in their nose. And so we do a surgery to straighten that out. So like I said, that's called a septoplasty. Parotidectomy is something where the parotid glands are your biggest saliva glands. They kind of sit on the sides of your face, right in front of your ears. And so it's pretty common to get lumps in there. And that's actually a pretty involved surgery. It's actually one of my favorites. I really like it, but we do what's called a facial nerve dissection as part of that. So your facial nerve, or the nerve that moves the whole half of your face on one side, runs right through your parotid gland. So what we do in the surgery is we actually have to dissect out that nerve and trace out the little branches. And then that allows us to safely remove whatever abnormal lump is in the parotid gland. So, it's like I said, it's a very cool surgery. I really like it. It's also a little scary though, to be working on somebody's facial nerve, because on the flip side of that is that, they could develop facial weakness or even complete paralysis of that side of their face, because of our surgeries. So it's something I don't take lightly, but like I said, it's a really cool surgery. And if you're ever in the OR and could see one, you'd be like, wow, like the anatomy is very cool in that. Direct laryngoscopy is a procedure that where we basically put a rigid metal tube in somebody's mouth and then kind of bring that down to the vocal cord area. And most commonly we're doing that if they have like a mass on their vocal cords, and we're biopsying it to see, is this cancerous? Or sometimes people develop benign nodules or cysts on their vocal cords. For instance, like teachers who are talking a whole lot can develop that. So sometimes they have surgery to remove those. Tympanoplasty is the name of a surgery to repair a hole in the eardrum. Neck dissections, again, something with really cool anatomy. So neck dissections are typically done as a cancer surgery. So you're removing the lymph nodes of the neck for patients to help with as part of their cancer treatment. And then repair of facial trauma. So we don't get that much facial trauma at my facility, luckily. But especially in residency, you do a lot of facial trauma repairs. So that's like mandible fractures, broken noses, mid-face trauma, that sort of thing. As I kind of alluded to earlier, there really are a lot of different working environments that has a big impact on your sort of day-to-day experience. And so academic medical centers, those are like Stanford or UCSF. So big places where there's a lot of tertiary care, a lot of advanced cases, so sort of more unusual or strange cases that are being done. Like I said, a lot of trauma is done there. So people there usually are fellowship trained. They're pretty busy, but they have more time that's spent either in admin or research or those sorts of things. Also, if you're in a job like that, you're teaching, medical students and residents. So some people like that, some people don't. On the opposite extent of the spectrum would be a solo practice. So that'd be, usually one person in practice by themselves, maybe sometimes two people. And on that end of the spectrum, you're really just in clinic all the time, sometime in the OR, and then you're also having to do your own business at end of things. So that's sort of a different challenge. And then more commonly nowadays would be group practices. And these could be either all ENTs, all head and neck surgeons, or they could be like what I'm in, a multi-group specialty where there's all kinds of different doctors. And as I mentioned, a lot of people that I know that are not at Kaiser have a much higher patient load, but they also have more time that they're in the operating room, I would say. So everybody's just kind of different, and it just depends on what jobs are available when you're done and what do you want your day-to-day to look like. Most interesting cases. So we have a lot of interesting things that happen. I would say more commonly, my interesting cases happen in residency, but so when I think about the facial trauma, which is kind of listed second here, those are both residency cases where, like I said, you just get a lot more trauma. One time there was an ATV accident. This woman, a mom, so she's probably in her 40s, and she literally, like, the middle part of her face, so like her forehead or her nose, was like wide open. You could see her nasal bones. She just hit, like, she was riding an ATV and she hit another ATV. And so that was a pretty crazy case. And then there's also one where there's a guy on a motorcycle and he collided with a concrete truck. And so he had all these wounds all in his head where he had concrete in there. So imagine trying to get a whole bunch of concrete out of somebody's scalp. We were in the OR for a long time with that case. So that was pretty crazy. And then the other case that kind of came to my mind as a really interesting case was an airway emergency that I had out in practice. So post-residency, this guy that I'll call the Russian, who showed up to the ER and had some infectious kind of symptoms. I think he was having a sore throat. And they just called me and said, I'm gonna admit this guy. I don't know if you're gonna come take a look at him. But they weren't really concerned about his airway at all. Usually if there's an airway thing, you kind of know that going into it. But I said, oh, yeah, I'll come over and, like, should I scope him? Which is that term for that flexible laryngoscopy using that little camera. And they're like, okay, whatever. But I just figured, okay, I'm gonna come scope this guy. And I look, and his airway was so swollen. He literally had like a millimeter between his vocal cords, which is not very much space. And I come out and I said, is this your normal voice? Because as you can imagine, if your airway is that swollen, you're probably going to have some voice changes. And he said, oh yeah, I've been talking funny for a few days or something. I was like, okay, well, we need to go to the operating room right now. Because basically what happens is that if somebody can't breathe through their mouth and have that go through their air tube, they need an emergency surgery where we make an opening into their neck, what we call a tracheostomy. And so that's something where, it's a pretty scary situation to be in, because the anesthesiologist can't really intubate this patient. And so you as a surgeon are responsible for very quickly trying to establish an airway so that the patient can breathe. And you're trying to do that in this situation, and in many situations, if they can't be intubated, you're doing what's called an awake tracheostomy. So that means the patient's actually awake as we're doing these things. So we're in the operating room, you got all these drapes and people and all this stuff going on, and you're trying to keep this patient to remain calm and remain still so that you can make an opening into their neck, into their trachea. So everything went well, but that was a kind of scary case. And so, importance of ENT surgeries. I mean, that's, airway emergencies, like I said, they're one of the most important things that we do. That's very, it's like when we walk into the room, we're really the only person that can do that can establish a surgical airway. So that's a very important and luckily not done that often thing that we have to do. But on a more day-to-day basis, we really help patients with all sorts of things that impact their quality of life. So we help them hear better, we help them talk better, we help them breathe better, swallow, all these sorts of things that really, like I said, impact your day-to-day life. And so when they leave our clinic, they're oftentimes really happy. So in conclusion, head and neck surgery is a very rewarding specialty that is, very hands-on, very procedural. And it's a long road to get here, but ultimately I think worth it if it's the right fit for you. Okay, any questions?
Yeah, if anyone has any questions, you can feel free to put them in the chat. Oh, okay. I think there are 2 questions in there.
Do I get Oh yeah.
Oh, yeah, go ahead.
Okay. Do I get called into the ER often? That's a great question. Yeah, good. Like I said, super awesome question. Not that often at my hospital. Where again, where you choose to have your job really impacts something like that. So in my job, it's actually pretty uncommon. We have a great group of ER physicians. We have we've also put a lot of time into setting up protocols and sort of giving them things that they can do on before the patient comes into our clinic, and then we try to have the patient just follow up in our clinic. Just because a lot of the things that we do really require special tools and equipment that we only have there. And so it's hard to do that if it's after hours or in the nighttime. And so, yeah, I said it's actually pretty unusual that I have to go to the ER. Call wise, let's see, I take on average 1 night of call per week and 1 weekend per month. But again, that is really going to vary depending on, where you work. Okay, let's see. Any tips you can give to high schoolers to succeed? And yes, you can email me with further questions.